Hi everyone, this lecture presentation is on managing chronic pain in general practice. My name is Nick Christelis. I'm a specialist pain medicine physician. I'm also an anaesthetist, so I got into pain medicine by the anaesthetic route. I only practice pain medicine now because it is something that I feel needs to be done. I'm the co-founder and director of Pain Specialists Australia. I have a number of other roles in the medical world. So what I'm about is essentially ridding the world of pain. It's a big why. There's a lot of people in pain, which we'll get to in a little while, but this is the focus of my practice. I also want to improve the practice of pain medicine and neuromodulation as one of the advanced pain therapies. So this is the discussion today on managing chronic pain. The pathophysiology, psychological basis to chronic pain. We want to look at the multidisciplinary and multimodal approach to pain. I'm going to pull out some evidence-based strategies. Look at allied health in detail so you can get a sense of how allied health can support pain management. Focus a little bit on non-opioid medications. Touch on interventional techniques, advanced pain therapies like neuromodulation, and then where and how to use pain specialists in your approach to managing chronic pain. So let's go all the way back to 1664. This is René Descartes', it's called Treatise of Man. And effectively, this was the first pain map or pain pathway. And it was defined, again, as a long thread that started on the foot, on the toe, and the heat from A did something to B and effectively opened a valve all the way at the base of the brain and let out these bad spirits. And that was the definition really in 1664, so René Descartes. The first pain pathway, which I think is fantastic, and it still has some basis even today. So this is what an average pain pathway looks like, and again, very basic. This is not what pain is, but it's more of an instruction. There are 4 parts to a pain pathway. There is the pain signal from the nociceptor to the spinal cord. From the spinal cord, there's a synapse at the dorsal part of the spinal cord, so the dorsal horn of the spinal cord, the back of the spinal cord. It then crosses over to the other side, and the second order of neurons travels up to the base of the brain, the thalamus. So one order from finger to spinal cord, second order from spinal cord to the thalamus, third order from the base of the brain to the cortex, and then call it the fourth order from the brain back down to wherever the pain was. So that's a very basic pain pathway. So sensation up and reaction down. That's what pain looks like. That's what nociception really looks like. And again, this is just the tip of the iceberg. What you have is on the left of the diagram at the bottom, you've got the nociceptor, the free nerve ending, which is complicated. It can be activated by chemicals, by pressure, by heat, travels up into the base of the spinal cord, so up to the dorsal root ganglion, then around to the top right-hand side of the screen, which is the synapse, the first order to the second order neuron. So that's the first synapse. That occurs in the back of the spinal cord, and then up to the brain. So pain and hypersensitivity is complicated. Now, how does this translate into the real world? Well, I'll come to this, but what we're talking about here is nociception. So that could be whether you are, it doesn't matter who you are, you activate a nociceptor. That is the first aspect of pain. But what I want to talk about, what we're really talking about is pain, not nociception. And pain is different. Pain is the experience of nociception, and this is the very important aspect that I want you to get your handle on. So patients hurt their foot, fine, they have nociception, they experience something, but it's the whole package that you're assessing, it's the whole package that you're addressing. It's the pain, but it's the person with pain that's so important. And have a look at this slide. This is based on functional magnetic imaging and how we're now starting to understand the cerebral signature of pain, how pain is perceived. And it depends on the context of pain. It depends on the cognitive set, which means it depends on attention, distraction, patients catastrophizing. It depends on that hypervigilance. So there's a cognition around pain. And catastrophizing is where patients are very heightened in their concerns and worries about pain. So they ruminate, they magnify the situation, they feel hopeless. If patients are catastrophizing, they've got poorer outcomes with pain management. You need to engage pain specialists early or pain services early, because good allied health can help patients with catastrophic thinking. Other aspects of pain, the patient's mood is very important. The chemical structure of the nervous system can change the pain experience. And of course, there's a whole bunch of other aspects, particularly the spinal cord, so the peripheral sensitization, the central sensitization that's occurring. So this is the pain experience, and this is what I want you to think about when you see somebody with pain. Another way of looking at pain and how it links with nociception, and these are from Luce's onion model of pain, which is fantastic and still very useful today. Nociception is the first part of it. And then you have the pain experience. So nociception is more the physiological aspect of it. And then you have the pain experience, which occurs up here. And then you have the behavioral changes and the suffering and other things that happen because of nociception and the pain experience. So these are the layers that we've got to peel back when we're managing pain. So when you see somebody with pain, don't necessarily focus straight on the nociception. Oh, you got foot pain. Let's give you a chemical for it. There are many other aspects that you need to think about. So I want you to start thinking differently when you're managing and assessing somebody in pain. We've touched on this before. This is the flag system. When you see somebody in pain, you've got to think about what the alarm bells are, if there are any. Are there any red flags that need urgent medical attention? Cancers, infections, fractures, neurology, cauda equina syndrome, if somebody's got backache. If somebody presents to you with backache, how do you know if it's important? How do you know if there's a red flag? If it's new, if it's severe, if it's associated with new neurological weakness, if there's changes to bladder and bowel function, these are red flags. They need urgent assessment attention. People forget about the orange flags. These are the patients with extremely high levels of distress, PTSD, substance abuse, and even personality disorder. So you might need to engage a psychiatrist in your overall treatment plan of patients. The yellow flags we'll touch on at a later point. That's where you get the allied health teams involved and a good pain allied health team. And then the blue and black flags, which people don't generally think about, these are related to the work experience, the work conditions. And if they're different or they're troublesome for the patients, you need to think about getting a team engaged around them. So I'm going to read it because it's important. Psychological comorbidities in chronic pain are common. How common? Say 1 in 2. So say 1 in 2 people that you see with chronic pain, and that's persistent pain, have some form of depression, anxiety. These patients have got lower pain tolerances. They've got poorer outcomes. They've got higher disabilities. They're more likely to have benzodiazepines. They're more likely to take opioids. They cope chemically. So the opioids in this situation flattens their anxiety, so they use opioids not for pain, but as an anxiolytic, the wrong use of opioids. And this is what the psychological basis is that we've mentioned. So they've got maladaptive, so they're thinking differently around their pain, cognitions and beliefs around their pain. My spine is broken. My surgeon told me that my spine is brittle and turning to dust. It's not. It's safe, it's stable. We need to change the way people believe. We need to change the way people think about pain. And that starts with you. It starts with a good pain team. Behaviours are very important around pain. People fear moving because it hurts. They stop moving. They get stiff. They get weak. That makes the pain worse. That reinforces these behaviours and beliefs. That triggers catastrophizing, makes their mood low. They get anxiety, they get depression, they get into this vicious downward pain spiral. They don't cope. They don't know how to cope. They cope the wrong way. They have an external locus of control. They blame somebody else for the situation they're in. They don't take it on board. I need to do this. I need to find a way through this. I need to find a team. So there are many aspects to the psychological basis of pain that you need to think about. And when you're doing a quick consultation, or when you have limited time, this is hard. This is why the important part is to alert yourself to the fact that these things are occurring. And if they're occurring, engage the right team for patients. And if you start off engaging your team and it doesn't work, or it's not proving beneficial, think about another team. I don't want to spend too much time on this slide, except I want to use this slide to show you how complex pain can be. You've got the pain experience, which is different for every single person. At the bottom of the pain experience, you've got that injury, surgery, inflammation, so the trigger for nociception, as we've mentioned. So you've got nociception, you've got the pain. And then so many factors around it. You've got sensitization, which is amplification of pain. So that's a neurological aspect of pain. You've got the hypersensitivity that occurs. You've got inflammation that sometimes occurs. It affects hormonal function. It affects metabolic function. It affects processing of pain, thoughts, beliefs, behaviors. And as you can see, people just get into this vicious cycle. So there ain't no quick fix for this. And as you can see on the left-hand side of the screen, medications alone cannot break the pain cycle. We need to move away from medications to managing pain. Injections cannot alone break the pain cycle. There are some treatments that are promising in terms of stimulating pain, direct brain treatments that are promising. And have a look at that bottom part of the slide on the left-hand side. Interdisciplinary treatment is the only reliable treatment for chronic pain. The multidisciplinary approach is vital in these patients. Sensitization. I want to use a very simple diagram so you understand what you're seeing. Normally, have a look at the top part of the diagram. You have nociception. You detect it. You feel it. That's normal. Sometimes the body becomes sensitized, so they feel, the neurological system feels things differently. And essentially sensitization is amplification of nociception, amplification of input. So you can either have normal nociception and it becomes sensitized, or you can have subthreshold nociception and there's sensitization. So you can have sensitization to normal pain. So normal pain is heightened, and that's called hyperalgesia. And you can have sensitization to non-painful stimuli, allodynia. All sensation hurts. Brush hurts. So that's when you touch a patient with a brush and it hurts. Is there neuropathic pain condition here? You touch a patient with a toothpick or something sharp and it hurts excessively in that pain area. So, evidence-based treatment options. This is from a paper looking at evidence-based options for primary care physicians. And there are some things that are evidence-based that we should be using, we should be incorporating. Physical therapies, exercise, psychological therapies, allied health, which I'm going to spend a bit of time on in a couple of slides because I want you to have an understanding about allied health and how you can engage allied health to manage chronic pain. We'll touch on non-opioid pain medications. I want to give you some tips and tricks on using non-opioids. Opioids are in brackets because they'll be discussed at a later point in a different presentation. I want to touch on interventional therapies and advanced pain therapies because they can help. And again, if used appropriately and correctly. And what you're seeing is we're using a full gamut of treatment approaches to manage pain. The aim is to prevent disability and maintain or even improve function. It's all about function. So let's go through this a little in turn, and these are aspects that you may choose to use on and draw on to manage pain. On the left-hand side of the diagram, medications. We've got anti-inflammatories. Use them if you can. Use them for acute, subacute inflammatory pain conditions. If they're not helpful or they're giving side effects, don't use them. If you've done a trial of them and they're not helpful, don't use them. Non-opioids we'll come to in a little while. These are anti-epileptic and anti-neuropathic medications. Some types of older and newer antidepressants we'll elaborate on in a bit. Lignocaine patches can be very useful for local hyperalgesic skin, allergenic skin. I know it's only PBS listed for postherpetic neuralgia, but you can still use lignocaine patches. You can even use a compounded analgesic cream. So if you want to try just a lignocaine cream or an EMLA-based cream, you can still just trial this to see what happens if a patient applies this 2 or 3 times a day to a hypersensitive area. But you need to have diagnosed the hypersensitive area first by your clinical examination. We'll touch on tramadol and tapentadol as well. I think tapentadol is quite a useful medication. It is a Schedule 8 opioid medication, but I think if you're going to go down that route, tapentadol is something to consider. There are many analgesic creams you can use. You need to prescribe them. Compound pharmacists might be able to help you with those, just for little areas of hypersensitive skin. Intravenous infusions are used by pain specialists in some situations. And as you can see right at the bottom, there's limiting and weaning opioid medications because opioids do not form a great part of managing chronic pain. Interventions, so the second bar, interventions can be drawn on. Things like epidurals, things like nerve blocks, things like radiofrequencing of facet joints, which we'll come to in a little while as well. And neuromodulation, so stimulating parts of the nervous system can be used to maintain, to manage and control some types of pain conditions. Physical therapy, I'm going to come to in a little while, but this is using a good allied health-based pain physiotherapist. Not necessarily a musculoskeletal injury physiotherapist, and I say this with respect, but a pain physiotherapist is different to an injury physiotherapist. And a pain physiotherapist is mainly non-hands-on. It's hands-off. It's a more active approach to managing. It's goal setting. It's reducing the deconditioning, reducing that boom busting that people get with chronic pain. So they do too much too quickly and then they're busted for 2 or 3 days. And they boom and they bust. And effectively over time their function declines. And then really reactivating patients, getting them to stretch, getting them to be a bit more flexible, changing coordination, endurance, and starting to pace out their activities. And as patients learn how to pace, their activity and endurance travels upwards. And then, of course, ultimately re-engaging. And the bottom of that middle bar, you can see it's all about self-management. I don't want patients to attend a therapist weekly for many months at a time. We need to get them self-managing quickly. Functional therapist, occupational therapist, I will come to in a little while. I'll spend a bit of time showing you how good a good pain OT can be in your treatment algorithm. And then psychological therapy as well. Same thing applies. Not just average psychology, pain-based psychological therapy. This is a treatment algorithm that you might employ. The bottom of the algorithm, the bottom of the graph is effectively rehabilitating patients as the psychologist, as the OT, as the physiotherapist sees fit in terms of that particular patient. Always educating and empowering the patient, giving them information. They need to understand what's happening in their body and why it's happening, and their bodies are safe. If they do that, they can get back on track. It's not uncommon that I see a patient and spend a good 40-45 minutes educating them on what's going on as part of the first consultation, giving them the tools, and they can go out there and start things changing and happening. So that's the first step. It's lifestyle change, understanding, non-opioid based simple medications. Say to a patient, your body's safe. Say to your patient, your body's not degenerating, your body's not deteriorating. Scoliosis just means a curvature within normal limits. These are the things you should be telling patients. We should be using the right terminology for patients. As soon as patients understand that The spine is not deteriorating. The spine is actually good enough for them right at this point in their lives. They've got ligaments, there is muscles, the spine is held together by many other things, not from that one disc that is degenerating. When I show patients their MRI scans, because I do that for most patients, I bring up their MRI scans and say, that's your disc. That's a normal disc. That's the disc that they've mentioned on the scan report. And patients go, oh, that doesn't look so bad. And it doesn't. When patients understand what's happening in their bodies, they feel like they can get on with things again. So it's very important that you normalize a lot of the terminology that's been used on patients along the way. And it's important that we start using the right terminology as well. Your body is safe. You cannot damage your body by moving it. You can damage your body by not moving it, because you get stiff, you get weak, you get anxious, you get frustrated, and the patients go, yes. So if we change the way we talk, we can give patients that power back again. That's the first step. We talk about weight, talk about improving diet, talk about the lifestyle changes, giving up smoking. So that's the simple first steps. Review often, see what happens, manage the medications well, which we'll come to in a couple of slides. And sometimes then drawing on a pain specialist for some forms of intervention if you can understand what the pain diagnosis is, and you may be able to give them a period of pain control with a block and a radio frequency and intervention that allows them to do the first step. So it's not just about using an intervention to just give them some pain control. It's about using an intervention as part of a plan so that you can allow patients to get on track again. That's a good way of using an intervention. So, allied health. We're educators. That's what an OT does. That's what a physio, that's what a psychologist does, amongst other things. But this is about educating patients, and that's why it is so very important. If you are not sure how to go about it, there are many books out there that we can use for patients. Our website has got a couple of ebooks that you can download for patients to read. So coping tips for pain, how do we talk about pain? So if patients understand, they can manage things. So the role of pain physiotherapy, I've been through this already. There are many aspects that a pain physiotherapist can address. Pain psychology. I'm going to spend a bit of time and I want to read a couple of things on this because I think it is so important. I see a lot of patients that have failed psychology because they haven't seen the right psychologist. And again, I say this with respect, but this is about pain management. The pain psychologist can improve the overall success of chronic pain treatment, providing a thorough evaluation of comorbid depression, anxiety, personalities, and coping and pain and suffering. Skip it down a little. There's motivational interviewing, cognitive behavioral techniques, coping skills. However, not all psychologists are created equally, and I say this with caution and respect, of course. But pain psychologist has got extra training in chronic pain, extra training in how chronic pain and these psychological aspects are linked, are mingled, go hand in hand, side by side. And I've gone through this again, and to spend a bit of time going on, stopping on each one of these points. This is what a good pain psychologist might help out with. So it's anxiety, depression, coping, sleep hygiene, which is so important for patients. Just print out a page from the internet if you haven't done already on sleep hygiene. No stimulants before bed, clean open bedroom, fresh air, clean sheets, no TVs, no iPads, no smartphones. There are so many things that are simple that we can do for our patients. Sleep hygiene. We don't have to go straight to benzodiazepines. A good pain psychologist will address these issues. Getting them self-efficacious, so able to enjoy a good quality of life despite the pain. Understand that this is a chronic medical condition, and if they understand that this is a chronic medical condition like diabetes, like asthma, like hypertension, there are ways of managing it. So again, we're educators. Remember, it always comes back to educators. Now, occupational therapy, whenever I talk to my patients about occupational therapy, they say, but we're not talking about work. This has got nothing to do with my work, and it's the same discussion over and over. A good OT, a good pain occupational therapist, is about how your body participates in daily activities in adaptive ways, how your body participates with the world around it. That is what occupational therapy involves. That is what functional therapy involves. It's about empowerment. It's about re-engaging them with the world around them and the activities that their bodies do. So this is what we should be talking to patients about. Again, just a couple of slides on pain OT. So this is about activities and participation. Have a look at the things that a good pain OT can do in terms of activities, participation, rehabilitation, participation, independence, identity, limiting occupational injustice. I love that term. It's really kind of focusing back on the patient. How the body functions, how it functions with the structures around them. Activity tolerance, allowing patients to tolerate activities, pacing them up. Yes, how the body and patients are involved with their environment as well. Absolutely, that's part of what an occupational therapist does. So have a look at it this way. There's the person, there's the environment, and there's the occupation, how that all goes hand in hand. Now, if I didn't say that this was an occupational therapist, you would say, well, this looks like a bit like a psychologist. You would say this looks like a bit of a physio. And there's a lot of overlap between these pain therapeutic pathways. Mindfulness, exercise, fitness, biofeedback, splinting sometimes, graded motor imaging, stress loading, breathing exercises. If patients are distressed, one of the simplest things for them to do, and I do this myself, when you're feeling stressed, when you're catching yourself breathing in short little shallow bursts, this is what I teach patients. Stop 3 times a day, take 10 or 15 slow deep breaths. You're changing the sympathetic parasympathetic nervous system balance, and they feel better for it. So sometimes on my treatment pathway on my patients, which everyone gets on their first consultation, deep breathing 3 times a day. You'll be amazed at how these simple little tips and tricks that you give to patients can help them. There are other ways of looking at pain management, and I'm not going to spend too much time on this, but it involves good nourishment. It involves motivating patients. It involves them understanding what's going on, in organizing their lifestyle, relaxing. So there are a number of other ways we can look at good pain, multidisciplinary, multimodal activities. Right, let's spend a bit of time on medications. Tapentadol. It's a good medication to get your head around. I think if we're going to talk about opioids, we should be talking about tapentadol. Opioids are a discussion that'll be had elsewhere. But if you're going to use strong pain medications, consider tapentadol. Here's a comparison between tapentadol and tramadol. A lot of people don't like tramadol because it can cause quite a bit of side effects. So 10 to 15% can get nausea, vomiting. It may not be effective, so have a look at the comparison between tramadol and tapentadol. Tramadol is stronger. In terms of the noradrenaline, NA, or serotonin, SE uptake inhibition, tapentadol has got more inhibition of noradrenaline than serotonin. Which is good because they're less likely to have serotonin side effects with tapentadol. Tapentadol is an active drug. It's not a prodrug. Its onset is quicker than tramadol, and it doesn't have any of that CYP 450 interaction, so it's a little bit cleaner to give to patients, but it is an opioid. It is a scheduled medication. You need to be careful when using it, and you need to have a plan. Have a look at that opioid lecture that we'll discuss this in a little more detail. Just a tip, tapentadol 50 milligrams is equivalent to about 10 milligrams of oxycodone, so it's not to be taken lightly. It's a strong medication, but it might be enough just to settle the waters if you're thinking about using a strong medication that's a non-opioid medication, maybe a little bit more for the mixed pain syndromes, the joint pain syndromes, and even the neuropathic pain syndromes that are not responding to standard antineuropathics, which we'll come to. So get familiar with tapentadol. Neuropathic pain is a lesion disease within the somatosensory nervous system. So something happens to the nervous system, triggers neuropathic pain, which we've talked about diagnosing, and we will do so in a second. What is allodynia? What is hyperalgesia? Well, the examination you undertake on your patients, you want to do a quick sensory screen. So you want to find out that painful part of the body. You want to see if there's an area of numbness. And if there is there burning, tingling, pins and needles? Is there allodynia? So does a brush hurt? All allodynia, all sensation hurts. Is there hyperalgesia? Does a toothpick or something sharp in that area hurt more so than a non-painful part of their body? These signify neuropathic pain. Have a look at that table. These are types of neuropathic pain conditions, so phantom pain, spinal cord injuries, diabetic neuropathy is a common cause of neuropathic pain, so you need to treat it as a neuropathic pain condition. Postherpetic neuralgia, HIV, chemotherapeutic agents. If patients had cancer and they're on chemotherapeutics, they're not necessarily going to volunteer neuropathic pain, which is relatively common, but you need to ask patients directly if they've got any pain conditions. Trigeminal neuralgia, multiple sclerosis, these are neuropathic pain conditions. That's just another way of defining or classifying neuropathic pain. Is it a condition that affects the central nervous system or the peripheral nervous system, or both? So assessing, so validated tools. Remember the DN4, you can get this from the internet anywhere. It's a quick questionnaire screener which is validated for neuropathic pain. Couple of questions, quick examination. We should be examining patients with pain. Are there any burning, pain, painful cold, electric shocks, tingling, pins and needles, numbness, itching? It's just yes or no. And if you score more than 4, I believe it is, then you're likely to get some form of neuropathic pain, and you need to treat it as such. Think about it, treat it as such. And of course, when you examine patients, 2 things could happen. They're either numb in that area of pain, so that's the hypoalgesic sensation, so it's numb, they don't feel anything, or it's hypersensitive, allodynia to brush, hyperalgesia to toothpick. And again, if you score 4 out of 10, you're likely to get a neuropathic pain. This is the treatment algorithm for neuropathic pain conditions. I want to spend a bit of time on this. We've got first-line therapy, second-line therapy, third-line therapy. I see a lot of time when I see patients, they're started on one of the therapeutic options. Lyrica is the commonest one. They try it, it doesn't work, or invariably it causes a side effect, and then the treatment algorithm stops. Don't do that. Try medication. If it doesn't work, move on to another medication, or combine 2 of these medications in low doses. Personally, I don't use Lyrica that often, if ever at all. I may use it in the perioperative setting just for quick absorption, but effectively Lyrica causes multiple side effects. We know this. Cognitive dysfunction, slowing of mood. It's obviously got some bad press lately as well, but we know this and we've seen it over the years. It can also cause weight gain, which is a big factor for patients. So I use a lot of gabapentin. Gabapentin is safer. It's cleaner in terms of its side effect profile, and it can be titrated upwards. Tips and tricks. 300 milligrams of gabapentin, which is the recommended starting dose 3 times a day, is equivalent to about 75 of Lyrica twice a day. So 300 is quite a strong dose. I normally start patients on a much lower dose, 100 milligrams 3 times a day, and each week they can titrate it upwards. Do that. You need to see these patients often so you can help them to titrate. Sometimes I get patients, if nighttime is a problem, take a little bit more at night. Rather than giving them benzodiazepine, might just use a higher dose of a gabapentinoid, or use a tricyclic, or combine the 2. So use gabapentin. Even though it's not on PBS, most patients are prepared to try it if they think it's going to be beneficial. So don't discount gabapentin. Amitriptyline has got quite a few side effects. I normally start people on 5 or 10 milligrams, just a small dose. Make sure they take it and see what happens. If they can't tolerate amitriptyline, which is NDEP, use nortriptyline, use something else. Don't just stop at that point. Commit yourself to diagnosing neuropathic pain, and then commit yourself to doing your best to get it treated. And again, combination therapy can be good. I also challenge you, if you don't want to use a sedative medication, use an SNRI, serotonin noradrenaline reuptake inhibitor. Use duloxetine, 30 milligrams in the morning. Even those, it is a bit of a stimulant, so they need to be aware of that, and the side effects can pass after 5 to 7 days. If that's not enough, or it's too strong, don't just stop there. Try another one. Use Effexor, 37.5 milligrams to start with. If that's not enough, use Prestique. So trial, if one's not enough or doesn't work or gives a side effect, trial another. Commit yourself to helping these patients. Before you move on to second-line therapy, and if you're going to move on to second-line therapy, if you're going to use an opioid, use either tramadol or tapentadol, whatever you feel more comfortable with using. And as I said a couple of slides ago, use tapentadol if you need to. Those numbers, the dose range, are pretty high, and most patients don't need all of those medications in those high doses. But if you can, and if they're tolerating them, you may need to titrate them upwards. Tapentadol, you're going to treat like an opioid, and you're going to manage like an opioid, which is a discussion on another lecture. Lignocaine patches can be used. Use them, particularly if you've got local areas of neuropathic pain that you've diagnosed now by your in-depth clinical examination and screening, looking for cutaneous sensory changes. Strong opioids are third-line therapy. They're there. They're another discussion. My recommendation is chronic pain and opioid therapy. Opioids are now kind of being drifted away from use in your average chronic pain patient, only for a small group of patients. I think if you're getting to third-line therapy or even second-line therapy and you're not winning with these patients, you should be considering engaging a pain services or pain specialist. Botox we can use, and it's normally used by pain specialists. It's something I certainly use for some forms of chronic pain, and it's been absolutely life-changing for some of my patients. Spinal cord stimulation is a valid, effective, safe option in some forms of neuropathic pain that is resistant to pharmacological treatments. There are pros, there are cons to using neuromodulation, but nevertheless it can and should be considered. There is an argument for using neuromodulation by a group of pain physicians, pain specialists, pain services that know how to use this therapy. It's like anything in medicine. Centers of excellence exist out there, and these are the centers that should be applying some of these therapies. Effectively what it is electrical impulses delivered to the dorsal part of the spinal cord. Remember that pain pathway where the first order of neurons synapse with the second order of neurons? If that area is treated with electrical stimulation, we can change pain processing. Tips for you. These are conditions that may be responsive to neuromodulation. So if you're seeing these kinds of patients, engage in a neuromodulation service. If your first-line therapies are not helping, if your first-line allied health therapies are not helping. Failed back surgery syndrome, terrible term for a syndrome that is effectively persistent pain following spinal surgery. Complex regional pain syndrome. So these two conditions have been widely studied in neuromodulation, and it is effective, it is safe, and it is long-term. Refractory angina, if it's non-obstructive refractory angina, neuropathic pain, spinal cord stimulation can be used. Most secondary neuropathic pain conditions, refractory, can respond to neuromodulation. And as you can see there are a number of other treatments, a number of other pain conditions that may respond to neuromodulation. This is what a good pain specialist should be able to answer for you. Diabetic neuropathy can be life-saving. Visceral pains are neuropathic. Pelvic pains can be neuropathic. So a number of pain conditions, including some spinal pain conditions, can respond to spinal cord stimulation. Not going to spend too much time on this. This is just showing you the changes that can occur at the dorsal horn of the spinal cord, the back of the spinal cord, if you apply neuromodulation techniques. So you apply little electrodes. So effectively, what happens is you can place little wires with electrodes, which are the black parts, in any parts of the nervous system, That's attached to a battery. And you try this out first. So the battery is placed on the outside of the body. So you place these wires through an epidural injection. The two pictures on the left, you can see right at the bottom of the screen, you can see those two little needles through which the wires pass. Those are the way you put the wires in. The needles come out. The wires are taped to the back of the skin. And then you undergo a trial. And if it's effective, then you may consider an implant. But again, it's got to be done for the right reasons, for the right patient, at the right time. There are many ways of applying this therapy. On the right-hand side of your screen, you can see it's applied to the pelvic region, so we're stimulating S2, S3, S4 nerves to treat some forms of pudendal and pelvic pain. If used appropriately, can be life-saving. Other validated treatments for neuropathic pain, pulsed radiofrequency, is effectively putting a needle on or near a nerve and pulsing it with low-level heat to change the neuroinflammatory and other aspects of the nerve, which can result in reduction in pain. It's been studied on the radicular pain, so cervical radicular pain, dorsal root ganglion, pulsed radiofrequency, suprascapular nerve, which is up near the shoulder, so for shoulder pain, inguinal herniorrhaphy pain, so post-surgical pain, even pulsing the disc or applying radiofrequency to a disc for discogenic pain. It's also been studied in testicular pain, so orcalgia. And that's what it is. You can see a spondylotic spine. There's a degeneration of the spine. There is scoliosis and a number of other factors. And this person wasn't deemed appropriate for surgery, or it was too risky to have surgery. So I applied a couple of needles onto the dorsal roots, pulsed them, and I see patients that can get anything from 6 to 9 months of good pain control. Again, this allows allied health therapies to be undertaken. So it's not just a treatment on its own, it's got to be combined with the other therapies that we've discussed. Ketamine infusions, lignocaine bisphosphonates infusions can sometimes be undertaken by a pain specialist. Nerve blocks for radiculopathy, yes. Epidural injections can be very helpful in some patients, and it can certainly bide some time to allow allied health therapies to start or be undergo. Spinal cord stimulation we've touched on as well. So there are some conditions that can be treated with interventional therapies. Opioid medications, for another discussion. We've got a lot to discuss on opioids. Interventional treatments, I'm going to read this out. When conservative management is not effective, or there are specific indications, interventional treatments can be considered. And this is about preventing risks, preventing side effects from medications such as opioids. And that's the way I approach this. If first-line therapy is not effective, if the allied health therapy is not effective, we consider whether it might be appropriate to use an intervention. It's good evidence for facet joint pain, which I'll come to. Good evidence for knee pain, so this is degenerative knee pain. Good evidence for acute radicular pain, and sometimes even using Botox for headaches. So, a lot of people get sent for facet joint blocks, and they can be helpful. But if you really want to understand if the facet joint is a trigger of pain, you've got to do selective medial branch blocks, which is undertaken by a pain specialist. It's just applying local anesthetic to the medial branch nerve. You can see where it is on the left-hand side of the diagram, the left-handed diagram. It lies just under the capsule of the joint. So if you block off the nerve and the pain goes away, you have a diagnosis, and then you can focus radiofrequency treatment on that nerve and provide short, intermediate, and long-lasting pain control. The best radiofrequency results I've had last between 4 and 5 years. These are patients that undergo the allied health therapeutic changes. So these are the patients that start swimming, start exercising, lose weight, understand what's going on in their body, and take control of the situation. That's how you use these therapies. So on the left-hand side of the left-handed diagram, you can see little bits of contrast outlining the facet joint medial branches, as well as on the right side, and you can see there's a fusion there. And normally when patients get mechanical pain around the fusion, it's from pain above or below the fusion. Those joints become really stiff, really sore, and that's where the load gets taken. So it's quite common for people that have had a fusion to get facetogenic pain above or below the fusion if, in your experience, you've examined and listened to these patients, they get that mechanical pain and it's not a neuropathic pain. Because remember, you're trying to pick up mixed pain or mechanical or neuropathic pain. And that's a pain score after a diagnostic medial branch block. It's got to be significant before you radiofrequency it. And then applying different types of needles onto those medial branches, where you apply the needle, put heat on the needle, and effectively you burn the nerves, so at about 80 degrees. And again, that can provide intermediate, sometimes long-term pain control if done for the right patients and the right reasons. Radiofrequency neurotomy. The same thing can be applied now to joints that are deemed either too young or too old for joint replacement surgery. The genicular nerves are the nerves around the knee. So if you've got patients that have had painful joints such as the knees and they're not responding to conservative therapies, and the patient doesn't want to see a surgeon, or surgeon deemed it's not appropriate yet for a number of reasons, get them to see a pain specialist. Let's see if they would be appropriate for genicular nerve radiofrequency. Here's some studies looking at it. 6-month follow-up. Average pain was about 3.3, so right at the bottom of that block. And that's a fantastic pain reduction when they're starting off with pain scores of greater than 5 or 6 that are debilitating. These are good treatments for the right patients. So you can see a couple of needles blocking off the genicular nerves. You can see the contrast around the correct area. And again, this was a comparative review, so systematic review of treatments for genicular nerve ablation. 80% pain reduction at blocks is very predictive. So if you do a diagnostic block and they get a significant pain control, it's very predictive of a positive result with a genicular radiofrequency. And same thing applies. If a patient's too overweight for a knee replacement, let's see if we can control the pain so it allows them to lose weight, it allows them to undergo allied health therapies, it allows them to get fitter and stronger, and see if we can help in that respect. That's a diagnostic block, so a positive diagnostic block. When to refer to pain specialists, a very important topic. There are specific pain conditions, issues with pain medications, even issues with allied health, and even preoperatively we can help. So pain conditions, if you're now an expert in pain assessment and pain management, so neuropathic pain conditions that may be appropriate. If they're not responding to first-line therapies, consider pain specialists. Pain after surgery. Failed back surgery, again, terrible term for pain following spinal surgery. Complex regional pain syndrome. If I can see these people early, within days and weeks, we can make a huge difference to them. If it's if it's months and years, it becomes much harder to manage CRPS. Pain specialists are good at this. Refractory angina, radicular pain, headaches, peripheral neuropathy, visceral pain, pelvic pain. If it's non-responsive to early therapies, consider engaging a pain specialist. Nociceptive pain conditions, as I've mentioned, hips, knees, shoulders that are deemed not ready for surgery or not appropriate for surgery, pain specialists. Facet joint pain, sacroiliac pain, spinal pain. And of course, those are nociplastic pains, which is abnormal nociceptive processing. Pain medications, if you're not winning with early first-line therapies, then consider pain specialists. If you're getting side effects from pain medications, consider pain specialists. If there are comorbidities with medications or patients are frail and they're on polypharmacy, consider pain specialists. In terms of opioids, the Faculty of Pain Medicine of the Australian New Zealand College of Anaesthetists recommend anything more than about 40 OMEDs, consider engaging pain specialists. And I certainly think if it's anything greater than 100 milligrams, if there's aberrance, tolerance, pain medications are not working, get a pain specialist involved. We've got a psychiatrist who's an addiction specialist as part of our practice, and we think it's a very important aspect of pain management in a group of patients. If the allied health is not responding, in primary care, you may need a tertiary pain specialist service that are trained in allied health approaches. And sometimes in the preoperative setting, you may consider patients with high pain scores, pain anxiety, pain worry, or a significant amount of opioids. You want a plan of action perioperatively for patients and post-operatively, because as As I know, a lot of GPs that I talk to and lecture to say to me one of the biggest factors of patients on opioids is that they get given these opioids in the post-operative setting. And this is something we're working hard with specialists and surgeons to reduce and so reduce that volume of opioid out in the community. We'll discuss that on another lecture.